Alors, est-ce que tout le monde est rentré?
Oui.
Alors, on va débuter. Bonjour à tous et à toutes. Bienvenue à cette activité du Pôle Santé qui aujourd'hui se fait en collaboration avec le CEPSEM et MedTech. Nous sommes heureux d'accueillir aujourd'hui Michael Marchbank. Ce sera une belle occasion pour aborder les stratégies mises en place par la Colombie-Britannique afin de rattraper le retard en chirurgie. Ces retards, vous savez, ont été vraiment exacerbés avec la pandémie de COVID-19. Nous pourrons aussi identifier les enjeux rencontrés lors du déploiement du plan de relance des chirurgies, le BC Surgical Renewal Plan, que cette province a déployé pour répondre à notre situation particulière, puis des solutions aussi qui ont été mises en place pour faire face à ces enjeux. On espère sincèrement que les leçons qui seront tirées de cette présentation pourront être transférables au Québec, car comme vous le savez, nous sommes aux prises avec des défis costauds en matière de retard en chirurgie. Je voudrais simplement vous glisser quelques mots sur Michael Marchbank. Il a été nommé par le ministre de la Santé de Colombie-Britannique à la tête du comité en charge de développer et de déployer un plan de relance des chirurgies pour la province. Il a auparavant été président et chef de la direction d'une des 5 autorités sanitaires de la Colombie-Britannique, le Fraser Health, pendant 4 ans. Il a également occupé les postes de vice-président du Royal Inland Hospital de Kamloops, de directeur de l'exploitation de la Provincial Health Services Authority, de directeur général aussi de la Health Employers Association de BC et de président-directeur général de la Fraser Valley Health Region. Récemment, il a accepté de relever de nouveaux défis et viendra aussi prêter main forte aux autorités de santé de l'Ontario, qui sont également aux prises avec les conséquences de la pandémie sur les listes d'attente en chirurgie. Nous sommes donc extrêmement privilégiés d'avoir avec nous ce matin un acteur de premier plan pour le déploiement de la stratégie au pays pour résorber les délais d'attente en chirurgie. Aujourd'hui, c'est Mme Nadia Benomar qui aura le plaisir de converser avec M. Marchbank. Nadia Benomar est coordonnatrice et chargée de projet au Pôle Santé depuis maintenant près de 7 ans. Elle suit de près toutes les initiatives et les développements dans le domaine de la gestion des soins de santé. C'est surtout une chercheuse aguerrie, minutieuse et extrêmement perspicace. Je suis certaine qu'il s'agit d'une interlocutrice de choix pour M. Marchbank aujourd'hui. En particulier, Nadia et moi, nous avons mené une recherche sur la situation de la chirurgie ambulatoire au Québec. Donc, je profite incidemment de l'occasion aujourd'hui avec la présence de M. Marchbank pour vous signaler que le lancement de cette étude s'effectue aujourd'hui même. Le document est accessible dès maintenant sur notre site. Notre rapport s'appelle « Le portrait des tendances et des pratiques de la chirurgie ambulatoire » et il va jeter un regard tout particulier sur le rôle des centres médicaux spécialisés, des CMS, dans cette dynamique. À la conclusion de notre conversation avec notre invité, nous pourrons donner un peu plus d'informations à propos de cette étude et des coordonnées pour y accéder, si vous souhaitez approfondir votre compréhension de la situation ici au Québec. Donc, sans plus attendre, je vous laisse entre bonnes mains avec M. Michael Marchbank et Mme Nadia Benomar. Nadia, c'est à toi.
Merci. Well, thank you, Michael, for being here today with us. Maybe I think for the audience, it would be great to maybe start with a brief presentation of the situation of elective surgeries in British Columbia and also know the impact that COVID had on waiting times there.
Okay, thank you very much. The one thing that I will apologize for up front is I am in my new home in St. Catharines, Ontario, and you may hear some noises from that, so please ignore those. That would be, I'd appreciate that patience. And thank you for the introduction and inviting me to attend today. So maybe I'll just start by giving you a bit of context, as you asked for, about BC, and I think it's important that you have some contextual pieces before we get into some of the details. As you know, or may know, BC is actually split into 6 health authorities, and in the introduction I've worked for several of them, so so you'll note that. And so it's organized under those 6 health authorities. The population of BC is about 5.15 million. and that would compare to Quebec's 8.6 million. So we're about 60% the size of Quebec. And so when I run through a bunch of numbers, which I'm about to, that's a bit of the context that helps you put that in. So our system currently has about 9,280 acute care beds, 28,000 long-term care beds, about 6,000 medical surge beds, 500 ICU beds, and 333 usable ORs as we begin to drill down into the ORs. The one thing that I will say is that physical capacity for the operating rooms is not a problem. Operating rooms traditionally are not used very much, seldom on weekends, and seldom in some late afternoons and evenings. So the physical capacity in most systems to expand surgeries is there. So that's not an issue. In BC, we shut down elective surgery from March 16th to May 18th of last year. And we began gearing up surgery on May the 18th last year, but it wasn't until June 15th that we were fully up and running, because it did take a little while to do that. A couple of other things around that is that shutdown resulted in about 17,000 patients being canceled. So that's with actual surgical times assigned to them. So they were going to get their surgery done at a particular hospital. And 15,000 people who had 15,000 surgical spaces that had not been booked yet. So as you know, you book about 4 to 6 weeks ahead. So that's 15,000. So that's about 32,000 cases. The other thing that happened during COVID is that the ORs themselves became 30% less efficient because of the uncertainty of the nature of COVID. You actually took extra precautions to ensure that the providers weren't at undue risk for the transmission of COVID. And so it actually became quite inefficient. I'm pleased to say that that inefficiency disappeared once people understood more about COVID and so on. The wait list that we were looking at in February of 2020, just before the shutdown, was about 93,000 patients. It then continued to grow and peaked in May, late May. Today it's about 82,000, so it's actually come down by 10,000. The next contextual piece that I'll cover is that in British Columbia, we're fortunate enough to have a data platform for surgery that covers all of the province. So all of the health authorities participate in the data platform. So things are all measured the same way. The definitions are all the same. And that turned out to be extremely fortunate, because in healthcare, you can sometimes get into debates about definitions and things like that. And so that was kind of eliminated. It's done by a company called Analysis Works, which was a BC-based company, but was recently bought by Logitech, who many of you may be familiar with in Quebec. So that has happened. And then the last contextual piece that I think really is important to understand is that the Minister of Health in British Columbia actually was very committed to their surgical renewal. He was very disappointed when elective surgeries had to be canceled. And he said it was one of his most difficult decisions to make because of the impact it has on patients. And so he was very committed to the renewal that we embarked on. And also the government itself committed $250 million to the renewal process. So we had that, both the Minister of Health and the central government's support for the initiative. The last thing I'll say is just to go back. We continued to do, of course, emergency surgery and most urgent surgeries during the shutdown. Those continued. So those volumes were there. So that's a bit of the contextual piece that I think you asked for, probably a little longer than you asked for, but hopefully that's helpful.
No, I think it's I think it will be extremely helpful for the audience to compare with Quebec. My next question will actually be about the main courses of action that you took in British Columbia in the surgical renewal initiatives, and what are for you the key success factors of this implementation?
So the first thing was the development of the plan to restart surgery, and it was guided by really three principles. The first principle was to involve the patients in the process. The second was how we prioritized patients, and the third was the infrastructure required to expand surgical time. The human resources primarily, and so those were the three plans. These plans and reports, the public reports that I'm going to refer to as we go through this presentation, are all readily available on the Ministry of Health British Columbia website. This was not, none of this was done in any kind of secret way. It was a very public process. In the plan, the first one involving the patients was really important. So we had all of the health authorities call every patient on the waiting list. That time they made about 100,000 calls because they wanted to check to find out if the patients were still willing to have surgery, because there was some risk associated with that because of COVID-19. And they also wanted to connect directly with the patients to tell them that they hadn't been forgotten, that we were restarting surgery. Were you still willing to go ahead with your surgery? The other thing that it allowed the system to do is it allowed the system to really dive deeply into the wait list. If you have a wait list of 90,000 patients, or in your case, I think it's over 200,000, not all of those are real. I can tell you that unequivocally sitting here today. And so you will call people who no longer want to have surgery. You will call people who have already had their surgery, and you will call people who unfortunately have passed away. So generally speaking, you will find an 8 to 10% attrition rate in your wait list. And that's important because it actually gives you a true sense of what you're facing. There is a significant margin of error in wait lists, and I think we have to recognize that. And that really helped us, and it probably contributed to the reduction somewhat of the wait list, including in addition to doing more surgeries. And so we thought that was very important, and it was extremely well received by the patients themselves. And I think you can't underestimate the importance of that as well. Now, the one thing that I will say is that we did have a kind of a check in the system where if a patient said, no, I no longer want to go ahead with that surgery, their physician was informed of that. Their surgeon was informed of that so that they could do a check, because a surgeon, in their professional opinion, may think that that might not be the wisest course. And we wanted to have those conversations happen between patients and their surgeons. So that was part of the process. The second principle was really to how we prioritized our patients. And so we prioritized our patients really in 4 buckets, if you like. Urgence, we wanted to ensure that urgent patients were getting done. We wanted to address the long waiters. Those are people who are waiting more than 2 times their clinical benchmarks. We wanted to look at canceled patients. And then we wanted to make sure that we were maximizing the straightforward daycare surgery cases and cases that can be completed outside the OR. Primarily in our case, that was cataracts, because most cataracts in British Columbia are not done in an OR, they're done in another setting. So And so we look to prioritize those patients. And when we get to the results later, we'll see that we did make significant progress. And the one thing that we had discovered in our wait list before COVID came was that the patients who were on the urgent wait list, it was beginning to become an issue. And so this was an opportunity to reset that, and we did. And we actually began to look at doing that. In terms of the new staff, we made a decision to invest money in training of two groups, operating room and post-anesthetic care nursing staff. So we started up training programs using nurses that were already in the system or new graduates who were interested. So we invested in that. We invested also in medical device reprocessing, because that was an area where we had some issues. And obviously, as you know, you can't do surgery without instrumentation. So we invested in that, and we're going to have to continue to invest in both those areas and other areas. Health authorities these days are going to have to become, or health organizations are going to have to become training organizations as well, because you'll certainly get lots of graduates from the educational system, but you will have to invest money in getting them specific skills to do the specific roles in the system. So that's coming. And all that was aimed at increasing the amount of time that we needed to do OR, so extending the days, because we had a number of ORs that closed at 3 in the afternoon. Didn't really make a lot of sense. And then maybe do evenings, weekends, and look at efficiencies as well. So that's really what the plan was that we looked at. And I can go into more detail on any part that people may be interested in, Nadia, if you want to ask.
Well, yes, actually, you talked about, I think, 2 points. The first one is the quality and efficiency improvements. You said that there were inefficiencies were by 30% due to COVID protocols, but you somehow managed to reduce that. So what were the specific processes that you were targeted? What kind of factors were involved? And we would like to know maybe how actually you managed to refine and update those processes to achieve efficiency.
Yeah. So we really took a whole system approach, and looking at health authority best practices, and also using the tremendous data that Analysis Works was able to provide us. So I'll give you a couple of examples. The first one was we looked across the health authorities for best practices, so to increase efficiency. So for example, one of the health authorities in British Columbia was a leader in reducing the need for anesthesia services delivered by anesthesiologists in gynecological procedures at our women's hospital. And so we look to expand those services across the province, because anesthesia availability is an issue. And so we looked at those kinds of things, and there were several examples of that. The other examples that we looked at were really provided by the data. So in our healthcare system, we're all a bit competitive with one another, but we don't really share very much data with one another either. And so with Analysis Works, I can tell you in all of the cataract centers, how many cataracts get done in a day. And the disparity is quite significant. And just by simply coming up to the average, if you're below average, or going to the 60th or 70th percentile, can make a huge difference in the number of cases that you do. And that's important in cataracts because it is actually the most common surgery that is performed. And the differences can be across the system, the size of BC or Quebec can be very, very significant. And that's just taking that data and looking at how many cases are done a day. The other thing we looked at in that is hips and knees. A number of centers in British Columbia have gone to a central intake model where the physicians work as a group and the patients are referred to that group, and the health authorities provide other staff such as physios and advanced practice nurses. They're actually the first point of contact for a patient who is referred by a general practitioner. And so it allows the physician group working with those folks to concentrate on the people who really need surgery, and then gives that patient the first available spot that's available. So so we really began to look at models like that, and you can do that in a number of different specialties. You can we also encourage health authorities to start to look at setting up centers of excellence, because a lot of people may not think like this, but surgery is really a production model. It's really about production. And the more you do, the better quality and the higher volume you get. So if you centralize hernias in a particular region to a single site, you will actually do better with the available time. And the advantage of that is you don't need to get any extra resources. Again, going back to anesthesia as an example, but other resources, because you just become more efficient. So those are some of the things that we looked at, and they are continuing to look at in British Columbia. And I would encourage everybody to do it.
The other one, and I think you mentioned it in the context, but also now with your answers, the importance of data and the importance of sharing information and being transparent between the authorities, but also with the patients and the citizens. So I think you relied heavily on real-time data. So how did British Columbia monitor this progress and manage to keep all the patients and the citizens informed?
Well, as I said, that the analysis work information was invaluable in terms of being able to have the same data and compare the same data across the whole province. And it's about standards and setting data standards. It's not about all being on the same system or any of that stuff, whereas some people will try to tell you that, but that's not true. It's all about standards. It's all about, this is how we collect it. This is how the definitions are. That's what it's about. It's not about, then the data can come in and the analysis works, people respond to the questions that the leaders in the organizations have. So it's, and the one thing that we did was we took the attitude that we wanted to be transparent with all of the health authorities. They hadn't necessarily seen all of the information from each other. And in some cases, inside the organizations, they hadn't seen the information between the various sites. So, but we were very specific about how we did that. We didn't, it's not a got you kind of thing, which is what some people fear. It's actually, we're here to share this information because I think, and we think it will make the system better. And it ultimately will benefit the patients. And that's what we're all here for. And when I talked about very competitive, all of us a lot of us in healthcare are trained. We're all type A's, and that's the first thing. And a lot of us are also trained not to be outside the norm. And so 99.99% of people want to do a great job. And when they see that information and it's presented in a way that's not threatening, they'll look at it and say, okay, you know, because people care about their patients. And that's really important. And they will respond. And that's how we did it. The other level of transparency that we put in place that I think helped overall the system is we publicly reported every month. We told everybody what we were doing. We told folks what the targets were. We said to everybody, this is what we're going to report this. And remember the contextual piece that I'll now introduce, which is for ever since I've been in healthcare, and my God, that's a long time, the whole surgical enterprise has been asking for more time and more surgical access. Well, here it is. There's $250 million. We have a commitment to train more staff. We have a commitment to add longer OR times. We have a commitment to do all that. And so here it is, folks. Now let's make the best use of it we can to benefit the patients that we have to. That's frightening, by the way, for a lot of people, just in case you don't know that.
Well, you mentioned it. You mentioned human resources as a key key element in deploying your initiative and the issues that you had in British Columbia. Here in Quebec, we have a very important personal shortages. And so what was your specific strategy regarding HR, and how did you tackle this issue in such a short amount of time?
Yeah. Well, I think the first thing we realized and began to appreciate is we're looking at significant increases in OR time. We're looking at and the other thing I think is it's not going to go away. We're suddenly not going to just increase this and then ratchet it back, because the demand for surgery continues to grow. Surgical wait lists are too long in probably most places. Certainly we're in British Columbia. So we were looking at an expansion of BC anyway, and though this is just a jump start, it's not going anywhere. It has to continue. So we have to do more surgeries. And so we certainly had to acknowledge that you can't ask existing staff to simply do more. That's not sustainable, and it's not the right thing to do. So we began to look at how best to do that. I talked about, we introduced training programs for nurses and MDR staff, and we will expand that going forward into other staff as well, or specific recruitment. And so we began to do that, and it was dedicated funding. The other thing that we did was we worked with the health authorities to ensure that the training programs were responsive. Some training programs can be quite long and lengthy, and you want them to be, in many sense, you're striving for them to be perfect. I would encourage people to look at options. There's shorter programs, and there's things that you can do to train folk. We worked with our post-secondary institutions to do that, particularly around MDR, as well as nursing. So we looked at that. We also began to look at physicians in terms of their availability. So we looked at the surgeons, for example, and said, you have to have the conversations with surgeons, and you have to say, if we're going to permanently expand by 20%, can the existing group do this, or do we need to recruit new physicians? And so those aren't necessarily the easiest conversations to have in the fee-for-service world, but it absolutely are discussions that had to happen, and we started to have those. The area where there were the most issues were anesthesia. And so we, in BC, there's about 525 anesthetists in the province, and 73 family practice anesthetists, so who are family practitioners. And these tend to be in smaller communities and medium-sized communities where they may do family practice as well as anesthesia. They have some additional training in anesthesia. A couple of things we noted is over time, anesthesiologists have been spending less time in the OR and more time doing other things. So I think the system has to start to look at that and see what that might mean. In British Columbia, we put in place a provincial template contract, essentially moving physicians from fee-for-service to a more predictable or a salary type arrangement. In that, there was an increase in compensation, but also certain other deliverables, i.e., hospital has this requirement for your services, you as a group commit to meet that. And so there's a quid pro quo, so we put that in place. I think also we began to look at other providers in the anesthesia world, so anesthesia assistants. I won't go into nurse anesthetists because that's not a productive conversation right now. And I guess the last thing is we looked aggressively at recruitment. We have a provincial agency that recruits physicians from outside in BC, from outside BC. It's called Health Match, and it has become quite expert at recruiting physicians from both inside Canada, but primarily from outside the country, and getting them through the immigration system, getting them through the various colleges and those kinds of things. So, and they're being quite successful at it. So that's what we have done there. The other thing is you really do have to, in all these areas, really dive down into in some detail. So for example, in some of our sites, we had casual and part-time OR nurses who wanted more time. And so let's mobilize using the resources we have to increase that time. With employees already there, let's make the use of it. The other thing, some of the other things is we provided notice, and again, for this year, traditionally there's a summer slowdown in ORs in BC anyway. And so we began to say, and that was more put in place more as a money saving exercise than anything else when it was first created. And so we began to say that's going away. So let's talk about how we make that happen. So, and then I guess the other thing that I'll say is one of the challenges is people are going to have to start working weekends or evenings, and that's a cultural change for surgery. Certainly for emergencies and urgents, yes, but electives, and so you need to think about how the system responds to that. For example, in BC, nurses who work on weekends get a weekend premium and things like that. So you really have to take a look at what that structure is, because that's a big part of the expansion of time. So I'll stop there.
You said that you had a lot of resistance, a lot of changes and cultural changes sometimes. Did you meet some resistance?
Everybody was happy to do it.
Okay.
I'm being a bit facetious. I think it's important to remember that this is a balance. I think the system when we first started up responded very, very well, very impressive, because the vast majority of people who work in the healthcare system, absolutely, we all care about our patients. And I think with the Minister of Health expressing his disappointment, I think that set a tone that we wanted to catch up. We wanted to help these people who had had their surgery, canceled. And I think there was a commitment early on, in the early parts of this, to respond to that. And so people did go a bit above and beyond, and that was great. But I think following on from that, we then had to say to this, talk inside the system, let's talk about some of the structural issues and some of the other things that we're going to have to do to continue to maintain this, because you can't kind of count on that lasting forever. And so that's, investing in training, sitting down and talking to the physician groups, both anesthesia, surgery, and the health authorities about this is permanent. How do we begin to change this? How do we begin to look at this? And always keeping in mind, the reason we're doing this is patients. Those patients need those surgeries. And it's up to us as a system to respond to that. And so it's having those kinds of conversations. Yes, people may want to get paid more for working on weekends, those kinds of things. But if you keep in mind the principles at the beginning, and then start talking about how do we make this happen, we laid out our plans. Okay, so let's have that dialogue. So that's how we kind of approached it.
I feel like the pandemic served as a catalyst for a lot of improvement, a lot of changes. What are the key takeaways that are I would say bound to remain, and those that will maybe be difficult to perpetuate once I would say the sense of urgency or the crisis will alleviate?
I'm not as convinced that yes, a certain level of urgency will disappear, but I think the number one thing in the Canadian system is wait lists, and the number one wait list that people worry about after MRIs maybe is surgery. And so and in BC, the system has kind of proved to the public by doing those 97% of those patients and seeing the increases in volumes that it can be done. I think it's very hard to go back. It's very hard to go back politically. So I think there's a momentum to keep going forward. And I think with the political leadership that is in place in BC and in anywhere else that does something similar, you have to retain that commitment, because it becomes so obvious if you don't. The wait list just goes. and that's a bad thing. And so I think you're right in the sense that the pandemic, for sure, jump-started a number of things, but I'm hopeful and optimistic that it will lead to permanent improvements in surgery, and I think if we pull together, it certainly will.
Maybe one last question, and then I will leave the maybe questions for the audience. Like it's been a year now. What are the I would say the results, and also what's next for British Columbia, but also for you, and maybe if you had to give, if you look at this year and you had to give an advice to Quebec, what would it be?
So, yes, we've had a lot of success. Yes, we've done 97% of the patients who got canceled. We've reduced our urgent wait list by 13%. We've seen, a 37% increase in the number of patients who've been waiting longer. The results are there, and you can look at them online. And a few things that I would say is it's important that, as I just said, that people understand the goals. The goal is to get more OR time. The goal is to do more cases. The goal is to be more efficient and learn from each other. And so it's having those conversations locally. It's taking a look at that. It's then reporting publicly and sharing the information that we have. So if somebody comes to us and asks, how is it that you can do on average 4 knee replacements in an OR day, and other people can only do 2 or 3. So it's having those kinds of dialogues. in a non-threatening way. It's really that working together. In terms of going forward, it's still continuing to focus. It's still really focusing on the things that need to happen. And if you look at the last report that's publicly available, you see 74 initiatives across the health authorities. A lot of those are quite small, but they make a big difference. And it's like really digging into it and really taking a look at it. It's not all the big picture stuff or the report that I wrote at the beginning. It's actually taking that and making it really actionable at a local level and working with the teams to do that. The big thing that I think is coming that really will take it to the next level is having groups of physicians working together to do orthopedics or to do hernias or to do cataracts or do those things, because those single entry models really do work and they really make a big difference. So that's one of the major initiatives that we need to go on. The other thing I would say is we have a terrible tendency in healthcare to have 85 million initiatives or 85 goals across the province or whatever. Streamline it. Like central intake is the way to go, make that the main goal. So what is this particular region doing to move that agenda forward? And here's the check marks, here's those kinds of, those kinds of things. So that's what I would say in conclusion.
Thank you so much. I think that we already have a question in the audience.
Yes. Yes, sorry. Thank you very much, Michael, Marchband, and Nadia. So we're going to open the questions. There is two ways to proceed. First of all, you can write on the chat box, or you can raise your hand and I will allow you to talk, and you can open your camera and microphone to talk directly to the guest speaker. So we have a hand raised, so you can go, Trevor Hennessy. Thank you very much.
Well, thank you very much for sharing your experience. I'm an ex-BC individual myself. Trevor Hennessy, Chief of the Department of Anesthesia in Gatineau, the CISO. Just one clarification. When you mentioned your shutdown just lasted until May, I'm assuming that was May 2021 or May 2020?
Oh, May 18th, 2020, and then it was a month to gear up to full operations on June 15th. That was 2020. Yes.
Okay, thank you very much. And
sorry,
what would you...
Sorry, just before I go on, and we have had recently in the last wave, we've had some shutdowns at a couple of health authorities because of the number of COVID patients in the hospital, and I think they ended up canceling an additional 2,100 cases. That happened most recently, but it wasn't a whole shutdown, it was very targeted. So.
Okay. With regards to your increasing of activities, which tend to be optimizing utilization of your operating rooms towards evenings and weekends, what percentage would you say are based upon increasing the work hours of your existing employees versus increasing your actual number and your staffing capacity? So do you have employees working 12-hour, 16-hour days, or have you changed the structures where you have double shifts or that sort of thing?
So I'd answer that question in a couple of ways. In terms of the non-physician staff, that's where we try to increase the availability of those staff. One of the measures that we put in place for the nursing staff in the OR and the PACU was to monitor their overtime. And we can do that provincially, and we did do that provincially, and we didn't, granted this information is a couple of months old, we didn't see a big increase. It was about the same as it was before. So it would be, that points to that it would be using existing casual part-time staff, newly trained staff to be able to do that. In terms of physicians, they tended to flex up and work more time, I would say. And utilize existing new recruits. So,
thank you very much.
I think there are several questions in the chat room where they're wondering, did British Columbia use private, I would say, private health clinics, private clinics to increase the surgery, the surgeries volume?
Yes, we did. Yes, we did. Having said that, the private OR capacity in British Columbia is quite low. We did add one new facility with 3 ORs and continue to maximize the use of the private centers as much as we could. Two things that I would say about that. The first was that in order to get the rule the provincial government said is that in order for a private center to receive work from the public sector, i.e. pay them per case, is that they had to be compliant with the Canada Health Act. That's a no-go. If you're not compliant with the Health Act, you will not get the private work, the public work. And the second thing is, you always have to keep an eye on that because you can inadvertently take staff away from the public system as well. So you do have to pay attention to that. Now, in our case, that wasn't a significant issue because it's not a large component of our system. But yes, we did maximize the use of those facilities as much as we could because that's existing ORs that are there and able to do work.
We have a question from Cindy Buteau.
Cindy, I think you can just, open your mic.
I have a question regarding the doctor's implication in the whole process. In Quebec, we seem to be pushing more demands on the doctor for the implication in the wait list, asking them to do the calls, the follow-up. And you seem to have, I don't know what type of professional was doing the first calls and filter those and minimize the direct implication with the doctors. I was just wondering if that was a choice or it's just the way that it works, because we've also been getting a lot of feedback from the doctors that it's not, to question this role that they're asked to do.
So in BC, you're not actually considered to be on the wait list until you've submitted a booking package to the booking office of the facility you want to have surgery on. So once we do that, then the health authority has all the information on the patient. And the health authority actually did all of the calling. It wasn't the physicians who did those. It was the actual staff at the following a standard script that called all the patients that I talked about, and will continue to do it on an ongoing basis because we want to make that wait list as accurate as possible. And clearly it's, unless you keep in contact with the patients regularly, it won't be as accurate as it needs to be. And so that's who made the calls. The only time, as I said earlier, the only time that it was passed back to the physicians is where a patient said, I don't want to have that surgery. And we wanted to give the physician the opportunity to, from a clinical point of view, have that discussion if necessary with the patient. So hopefully that answers the question you're asking.
I have a second question also in the prioritization of the cases. Here in Quebec, these are like an ABCDE system, which is not perfect, which seems to omit certain quality of life aspects because someone being on wait list a long time can have an impact their job or whatever. So I don't know what type of prioritization. I know you said urgency, but how did you have guidelines to define those?
Yes, they are defined and quite a lot of detail. The one thing that we decided to do is we were not going to change that. We weren't going to have a discussion at this point about when we were doing the renewal and the restart to have those kinds of discussions, because those discussions, generally speaking, take quite a long time because people get very interested because they see that, for affecting them quite directly. So we just went with the current system. And so the only change that we really looked at making was when we define urgent. Now we define urgent as anything that has to be done within 28 days, regardless. And so that was really the only tweak we made. The rest we just left in place because it's an elongated process to change those things. And so we felt we didn't have that time.
Okay, thank you.
Thank you very much. We'll alternate between hands raised and chat box. So we have a question from Daniel Boily that is asking, in Quebec, the limited access to nurses seem to be the main constraint for surgery plan. And what is the situation in BC?
The situation in BC is tight for nurses. And so when we looked at that, if you read the initial renewal document, it said that every graduating nurse in BC should be hired by somebody in BC. And when we meant hired, we meant you've now got a casual position, or you've now, it's a permanent position. You should be hired into a permanent position. We need to loosen this up a little bit, and we need to actually say, we will find you part-time and full-time work if that's what you want. And most graduates want that because they want to consolidate their skills. And then once they're in the system, then they can make choices, and that's why we offer the training programs in the OR and the PACU particularly. So because there's med-surg nurses who want to do that and so on. So we really have to get, I think, we sometimes have really paid too close attention to the budget, and this is an anathema for an administrator to say this, by the way. We paid too much attention to the budget. I think we've been penny wise and pound foolish, and I think that shows. So I think we need to rethink that, and we need to take a look at that, because you know what? The demands for healthcare workers are only going to grow, and so we really need to think about this in a different way if we're going to be successful.
Thank you very much. We can ask Jennifer Pepin to talk.
Hello, thank you. Jennifer Pepin, Institut Centre-Ouest. The question I have is sort of similar to Danielle's. Here in Quebec, we had a lot of nurses that were redeployed from the OR, so a lot of OR shut down and these nurses were sent elsewhere. And one of the issues we had is bringing them back to the OR for different reasons. So I was wondering if you had any thoughts on that. What kind of issues did you guys face?
We didn't, that really never came up as an issue for us about bringing them back. Obviously, that was one of the reasons that it took us a month to gear up, was to bring them all back and do all those things. But that never really was an issue because I think OR nurses really like to be OR nurses, and to some extent the same with PACU. So so we didn't have that as a problem. So I can't speak to that. Nobody ever articulated that for us.
So just a quick second question. You spoke of reviewing your training programs. Would more information be available in one of the reports you spoke about earlier?
No, it probably won't. That's probably just a bit of editorial comment. I can add a little bit. In British Columbia, we had a particular educational facility that offered a lot of these courses to become an OR nurse, to become PACU, and there was capacity issues with that. And so some of the health authorities began to look at systems such as, there's one in the States called ACORN, I believe, and other programs that actually were provided a good level of training for OR nurses. And so they really worked together, the educational facilities do some, but the health authorities are taking over doing them themselves. So I don't pretend to be an expert in that.
Okay, thank you.
The next question is from Michel Picard that is asking, you mentioned the HR aspect, including the training of MDR employees. Is it an internal training approach specific to each hospital, or rather a training approach at the level of schools on the part of the government?
In BC, I'll give you the BC experience. There were some community colleges, which that may be CEGEPs in Quebec, I'm not sure, who offered certificate programs in MDR. So we, where that was possible, we partnered with them to offer that certificate program and work with them to say, we've got a tremendous volume here. Let's figure out how to do this together and get that certification. And then there will be some other health authorities who have gone and done it on their own as well. But it's very nice to have a certificate from a community college, because that provides the employee with mobility and a certain standard of training.
Thank you very much. So is there any question that is coming as a surprise? We're about to close the meeting.
Are you asking me?
No, I'm sorry. I was asking to everybody. So we don't have any more questions, so I can let maybe Marie-Hélène.
Of course. Thank you very much, Michael Marchbank. It was really, really enlightening. Je vais poursuivre en français. Je vous remercie encore une fois au nom de tout le monde. Je remercie aussi Nadia qui a mené cette entrevue de façon vraiment avec des très bonnes questions. Merci beaucoup pour avoir éclairé. Merci à tous aussi qui est intervenu dans cette conversation. Je pense que vraiment ça nous aide beaucoup pour le futur des services opératoires au Québec. Je vais clore cette rencontre-là en vous disant, tel que je vous l'ai promis au départ, que vous pouvez prendre connaissance de notre étude, portrait des tendances et des pratiques de la chirurgie ambulatoire. Le lien va vous être directement transmis pour tous ceux qui se sont inscrits au séminaire. Vous pouvez aussi y accéder sur notre site Pôle Santé, ou d'ailleurs, vous pourrez avoir aussi accès à beaucoup d'autres types d'informations ou d'autres rapports que nous avons publiés. Il y a certains d'entre vous qui avaient demandé dans le fil de discussion des références que M. Marchbank a citées. Je vous confirme que plusieurs de ces éléments-là sont disponibles dans notre recherche, dans la bibliographie de notre recherche. Je veux remercier nos partenaires SEPSEM et MedTech pour le soutien de la diffusion de ce séminaire. C'est extrêmement apprécié. Je voudrais aussi profiter de l'occasion pour vous inviter à 2 événements qui vont compléter notre programmation de cette année. En fait, on a une semaine qui est très faste parce que les 2 événements sont demain et vendredi. D'abord, demain, midi, Mme Valérie Bélanger, qui est professeure agrégée au département de gestion des opérations et de la logistique, va nous entretenir de la planification des services préhospitaliers d'urgence. Nous vous donnerons le lien dans le courriel que nous allons vous transmettre si jamais vous voulez vous inscrire. Alors, c'est programmé à midi. Deuxièmement, pour vendredi matin, le Carrefour Logistique, le Pôle Santé et MedTech se sont réunis pour vous inviter à venir échanger sur la résilience des chaînes logistiques en santé. Il y a plusieurs chercheurs et praticiens qui sont invités dans le cadre de cet événement qui, je pense, n'est à ne pas manquer. Vous aurez l'occasion d'entendre notamment Claudia Rebolledo, qui est professeure titulaire à HEC Montréal, Jacques Roy, qui est aussi professeur titulaire au même département de gestion des opérations et logistiques, Martin Beaulieu aussi, qui est chercheur associé au même département. Et nous avons Catherine Blanchet, qui est responsable du développement des affaires pour la société Optimal, et Élise Maheu, qui est directrice Government Affairs and Markets à 3M Canada, qui va venir nous parler de ce sujet qui est vraiment extrêmement intéressant avec le contexte de la pandémie. Vous pourrez également avoir le lien pour nous joindre dans le courriel qui va vous être acheminé tout à l'heure. Bon, j'espère que vous pourrez vous joindre et je suis vraiment certaine là, que vous allez y trouver votre compte pour les besoins de notre bon réseau de la santé. Alors, je termine en vous souhaitant une excellente journée et aussi vous remercier de votre attention pour aujourd'hui. Et n'hésitez pas à communiquer avec nous pour toutes autres informations. Merci.
Thank you.
Thank you, everyone.
Merci à tous.